ARDS. And the question is when and how. This is Luciano, as you know, and this is Ted Kolobov, the man who actually invented the first practical membrane lung. You used to say, do the right thing, but do it right. And this is true for ECMO. You have to do ECMO at the right time, when it is the right time to do for the patient, but then you have also to do it right, otherwise you get into problems. ECMO became popular again in 2009 when the CESAR study was published, showing an advantage in outcome in patients that were sent to an ECMO center when compared to conventional treatment. Luckily or unfortunately, the same year, 2009, H1N1 pandemic started around the world, and our colleagues in Australia and New Zealand confronted during the summer that in their country's winter, the first severe ARDS cases due to H1N1, and they treated many of them by ECMO with very good results, I must say. So when do we see an indication for ECMO? If we accept the idea that ECMO is clinically useful. And I think these days we can accept that idea with some limitations. When, according to the Extracorporeal Life Support Organization, ECMO should be considered when the chance of dying are around 50%. That means really severe ARDS, and should be applied. It has a sure. It should be applied in all cases when the risk of dying is equal or more than 80%. In practice, what happens is that patients connected to ECMO are connected to ECMO when they have an FiO2 of 97% average, PO2 of 69, PO2 FiO2 around 70. PCO2 often is quite high, permissive hypercapnia, pH lower than normal, 7.26. Peak inspiratory pressure quite high on the 40. Mean airway pressure 26 and PEEP 13. I must tell you that in recent years, these airway pressures and mean airway pressure have been going down because we are more and more aware that high airway pressure inevitably lead to ventilator-induced lung injury and deteriorating lung function. In the CESAR study, we had also exclusion criteria, and those are quite reasonable. High pressure or high FiO2 for more than 7 days. It means mechanical ventilation for more than a week, and we'll see why. Intracranial bleeding, obviously, because we need anticoagulation. Or moribund conditions. We must have a chance of survival. Our colleagues in France, whatever, have developed a couple of scoring systems to evaluate the outcome, to predict outcome for ECMO. We did our own in Italy. I think this RESP score, made in Paris from data all around the world, is quite good. It takes into account age, immunocompromised status, diagnosis, central nervous system dysfunction. I cannot go through the long list. It will take 10 minutes. But the system works quite well. It is actually been developed on patients once they were connected to ECMO, not before connection. But anyway, it works quite well. And one of the parameters that increases the risk substantially is in patient having been ventilated more than a week. However, at least in our center, we do not consider it an exclusion criteria. But we know that it's not a good, it does not improve prognosis. It makes prognosis much worse. This, in Bob Bartlett's series, published years ago, more than 10 years ago, already more than 8 days ventilation increased the chance of dying more than 5 times. So when you meet the criteria, but most of everything early, do not wait too long. The earlier, the better. How? Because we do not have just to do the right thing. We have to do it right. Because ECMO is a complex procedure. It requires experienced people, adequate services in the hospital. It requires anticoagulation. This is the very good experience from Australia and New Zealand from a simple disease, H1N1. H1N1 is a simple disease because it's a viral disease, single etiology, young people usually. Death rate is very low. But out of these died patients, 2/3 died because of hemorrhagic complications. If they did not add hemorrhagic complications, death rate would have been 5% probably. So the major risk of extracorporeal circulation, high flow extracorporeal circulation, still is hemorrhagic complication, intracranial bleeding and major bleeding. But let's go back to the real thing. We want to get a better lung out of the natural lung of the patient. We want the lung to heal. And what do we do with the patient's lung? First of all, we start at the same mean airway pressure. Nobody measures mean airway pressure, but it's very easy. Every ventilator displays the mean airway pressure. Nobody looks at it. But mean airway pressure is a compound measurement of how invasive is our ventilation. We decrease frequency. Many do not decrease frequency. So I think decreasing frequency is good. I always discuss with my colleagues about respiratory rate in bypass. Decrease tidal, decrease the IE ratio. A long IE, if you have a long inspiratory time, you have a long time at high pressures. I mean, it's as simple as that. Then there is a problem of recruitment. Should we recruit the lung or not? I will not get into this discussion. And remember that for oxygenation, we need high blood flow. High blood flow is, if blood flow is not enough, do not get into the serious mistake of increasing central venous pressure to get more blood out of the patient. That is the wrong thing to do. You should change cannulation or change patient, but do not fill up the patient like a barrel of beer to get more beer out. So these are the This study was recently published. I think this is the one Luciano was referring to. And you see that tidal volume in average around the world goes down from 6 to 4 milliliters per kilo, respiratory rate from 20 to 15, 16, sometimes 20. PEEP stays the same. Plateau pressure goes down below 30 for sure. These are our own data, and we, as you see, we do not decrease much PEEP. Yellow are survivors, red are not survivors. PEEP is not decreased much. Plateau pressure goes down from over 30 to somewhere between 25, 26, it depends. Tidal volume goes down lower, sometimes around 3. Respiratory rate drops down from 30, 35 to 10. Because I keep saying, decrease that rate, decrease that rate. But when you go lower than 6, the alarm sounds. So you cannot go lower than a certain rate. We apply ECMO because the patient is hypoxemic. But what we want is to have a decent oxygenation with a less invasive ventilation. This is the experience of Palmer in Sweden. And you see that it starts with with mean airway pressure around 25, and then it decreases the mean airway pressure the same way we do. But look at oxygenation. Before cannulation, saturation is 85% arterial. During bypass is lower than 85, 82. So the target is not to have a PO2 of 150 or 100% saturation. No, the target is to decrease how much you spend in pressure and ventilation to achieve the oxygenation. Then, at a certain time, we think that we should move from controlled mechanical ventilation paralysis to assisted breathing. But we have to do that at the right time. If we do it too early, like in this patient, then we have esophageal pressure swings of 30, 35 centimeters of water. And that is very dangerous because it causes lung edema. When the patient recovers, then we can show that the respiratory rate and tidal volume and drive of the patient is controlled by the gas flow of the ECMO machine. The lower the gas flow, the higher the drive. If I want to control the drive, I increase the gas flow. If I want the patient to breathe more, I decrease the gas flow because in so doing, I change the CO2 removal. Keep in mind that most of the times ECMO is not a short procedure. It was short with viral diseases, with H1N1, but in our series, ECMO, in average, is 26 days. Length of stay in ICU is 43 days. And the patient was moved from control to assist after more than a week. It takes time for the lung to heal. We think that referring patient, centralizing this patient is good. We should have a system that refers these severe ARDS patients, candidates for ECMO, to a center that has a high enough volume to have enough experience to treat those patients. And for sure, we have a network in England, we have a network in Italy, in France, something is organized. And well, this slide is a picture of Bob Bartlett, who clinically initiated all this. But to conclude, in the last 10 seconds, when to do it? when the criteria are met, when the risk of death is high, and that might be due to gas exchange or very invasive ventilation. When you are paying too much to get a decent oxygenation, do it early and do it right. Do not improvise. I think every country should have a system organized for ECMO referral. Thank you very much.
Thank you, Antonio. We have time for questions. Yeah?
Hello?
It works.
It's not working. My question is, why are you still using so high PEEP on ECMO?
Can you speak on the microphone, please?
It doesn't. All right. My question is, why are you still so high PEEP on ECMO? We don't use it, and I think that our numbers are not any worse. There are some data that intrathoracic pressure may even worsen mortality.
Can I answer? My mom said you should never answer to a question with a question, but which kind of PEEP do you use?
Well, most of the times we are around 10 or even less, and as I said,
our PEEP is 14 usually, between 12 and 14, but what you might have seen higher PEEPs than that, because we have a higher PEEP to maintain average mean airway pressure at the start, and then we go down in days to avoid flooding of the lung. Many of these patients have been managed with very high PEEP and are relatively hypervolemic. If you drop PEEP, at least. And then the level of PEEP depends on respiratory rate, because if you decrease the rate, the mean airway pressure goes down much more. And so, as you have seen, we use between 2 and 4 centimeters of water higher than you, probably because we use a lower rate. But I do not hold the truth. Any other question?
Antonio, you said that you have a network in Italy with referral center. Do you have a checklist when a center phones you to say, I have a patient with severe ARDS? Do you have a checklist with strict criteria, or is it
quite loose? It's quite loose. We have indications to call, but then we transfer the patient, and every center decides whether to transfer the patients on ECMO or before ECMO.
So, for example, if a patient is severely hypoxemic and the center says...
It's much safer to transfer on ECMO.
Yeah, but do you ask for every patient to have a trial of a prone position, for example, before?
It depends. In some center, we take the patient and prone him late at our place. It depends on the center, because not every center, as an example, prone patients. Not every center uses. We still use nitric oxide in many cases to see whether we can manage oxygenation.
Yeah, Antonio, very nice talk. Just a quick question about the respiratory rate on patients under the ECMO. There's quite confusing data literature on that subject. You mentioned that you were aiming for very, very low respiratory rate, around 5, 6. How do you do that? Do you paralyze the patients up to 1 week? Because in my expertise, most of these patients have a strong drive and they need...
We paralyze them often for a week.
Okay.
I don't know which is your experience, but
we paralyze them, yeah.
The drive is very high.
Yeah,
I showed the slide with 35 centimeters.
Yeah, swings.
swings. And
yeah, it's also our experience, and most of these patients need, even if you drop down the PaCO2 down to 20, they still have this very strong drive, and
even at 7.5 of pH, they still have a very high drive.
Okay.
Sorry. Have we got time for another question? Sorry, Nagesh Bandla from UK. This may be slightly outside your topic, but what is your experience in outcomes in people with autoimmune disease and profound immunosuppression with ECMO and ARDS? Doing what? Severe autoimmune disease, profound immunosuppression, do they do well on ECMO with ARDS?
They do better than without ECMO, most probably. We tried to manage them without intubation, but we're not successful in most cases. And the survival is much lower. Our series is not big, might be 10 cases, but the literature, the available literature is really univocal, that the death rate is much higher than in non-immunocompromised patients.
Thank you.